Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
When you think about cancer, what often comes to mind? For many people, I imagine it's a disease that mainly affects older adults, something faced later in life.
That's the typical picture, yes.
But what if I told you there's a shocking, truly alarming trend that's just completely rewriting that narrative, especially when it comes to the digestive system? We're seeing this dramatic, really unexpected rise in what researchers call early-onset gastrointestinal cancers. So these are diagnoses in people under the age of 50.
That's right.
And here's the statistic that really, it just makes you stop and think. For men, early-onset colorectal cancer, that's cancer of the colon or rectum, is now the leading cause of cancer-related death under 50 in the U.S.
Leading cause. Wow.
And for women under 50, it's the second leading cause. I mean, that's not just a number. It's a huge shift in generational health.
It truly is. And, this isn't just an American issue. It's a concerning global increase we're seeing, particularly pronounced in high-income countries.
Right.
And what's really striking is what researchers are calling a birth cohort effect. Basically, this means that more recent generations, people born later, are facing a significantly higher risk of developing these cancers than previous generations did at the same age.
So someone born in, say, 1990 has a higher risk than someone born in 1960, even when they're both 40.
Exactly. That pattern strongly suggests fundamental changes in our environment. Things like our diet, our lifestyle, maybe exposures early in life. But the precise combination of drivers behind this and why it's happening now, that's still largely unknown. It's a really complex puzzle.
Okay, so let's try and unpack this. Our mission today is to take a deep dive into the very latest research. We've been looking at a really comprehensive paper in the British Journal of Surgery by Sarah Char and her colleagues, and also a related health news article.
A key study, yes.
We want to understand the true scale of this problem, explore what factors might be contributing, shed some light on the unique challenges these younger patients face, and ultimately figure out what this all means for everyone listening, for you.
Precisely. This review we've examined, it gives a detailed look at the epidemiological trends, basically, how common these cancers are becoming. It digs into the risk factors, the clinical features, the molecular characteristics, even the genetics, and crucially, patient outcomes.
And it covers several types.
Yes. While it touches on several gastrointestinal cancers, the main focus is on colorectal, esophagogastric, that's the esophagus, your food pipe, and stomach and pancreatic cancers. It's trying to piece together this complex, evolving picture.
Let's start then with colorectal cancer, because that seems to be where the story is just so dramatic. It's this really stark contrast.
It is.
If you look at the overall rate of colorectal cancer in the U.S., standardized for age, it actually decreased quite a bit between 1985 and 2018. That sounds like progress, right?
On the surface, yes. Better screening, perhaps better treatments for the older population.
But here's the twist. At the same time, early-onset colorectal cancer, the under 50 group, has seen this marked, consistent increase in both men and women in the U.S. since the mid-1990s. It's like two completely different trends happening at once.
The data really highlights that paradox. For example, the age-adjusted incidence, the rate of early-onset colorectal cancer in the U.S., went from about 6 cases per 100,000 people in 2000 up to over 8 cases per 100,000 by 2017.
Okay, so a definite rise.
A definite rise. But what's even more, staggering, is the generational comparison. Compared to adults born back in 1950, those born in 1990 have double the risk of developing colon cancer.
Double.
And wait for it, 4 times the risk of developing rectal cancer.
4 times? That's massive.
Yep.
Just one generation.
It's a huge leap. And CDC analysis backs this up, showing an incredible 185% increase in colorectal cancer among people aged 20 to 24.
Wow.
And even more shocking, a 333% increase among those aged 15 to 19. We're talking teenagers here.
That's almost unbelievable. And you said this isn't just a U.S. thing.
No, not at all. We see similar patterns globally. A study across 20 European countries found significant increases for individuals in their 20s, 30s, and 40s. It's widespread in developed nations.
So this generational acceleration of risk is clear, but something else you mentioned, it's not affecting everyone equally, is it? There seem to be disparities among different racial and ethnic groups, certainly here in the U.S.
That's a very important and, frankly, concerning dimension.
Yeah.
A National Cancer Institute analysis looked at data over several decades, up to 2009. It revealed some significant differences.
Like what?
Well, for instance, doctors diagnosed 16.5% of American Indians and Alaska Natives with colorectal cancer before age 50. For Hispanic patients, it was 15.4%. For Asian and Pacific Islanders, 12%. And for Black patients, nearly 12%.
Okay.
Now, compare that to non-Hispanic white patients, where only 6.7% were diagnosed under 50.
That's a huge gap, more than double the rate for some groups compared to white patients.
Exactly. It shows a clear, concerning difference in who is bearing the brunt of this early onset disease.
Yeah.
We need to understand why these disparities exist.
Absolutely. And while colorectal cancer is maybe the most talked about example, you hinted it's not just limited to that. Are we seeing similar trends, maybe less dramatic but still worrying, in other parts of the digestive system?
Yes, unfortunately we are. The research indicates that rates of pancreatic cancer,
Yeah.
esophagogastric cancer again, that's esophagus, and stomach appendiceal cancer,
Right.
and biliary cancer, which affects the bile ducts, are also rising in people under 50.
So it's a broader GI issue.
It seems to be. Appendiceal cancer, for instance, cancer of the appendix, is rare overall, but it actually had the greatest increase in incidence across all cancer types in the U.S. between 2010 and 2019, a really high annual percentage change.
No, I wouldn't have expected that.
Right. So while colorectal cancer is leading the charge in terms of numbers and impact, it seems to be part of this wider troubling pattern across the gastrointestinal system in younger people.
Okay, so if these rates are soaring, especially in younger folks, the big question, the one everyone asks, is why? What are researchers thinking are the main culprits? You mentioned it seems to point towards modifiable risk factors, things in our lifestyle, maybe.
You're right, that's where a lot of the focus is. The research points to several key factors, and their combined effect seems pretty significant. Obesity is a big one.
Especially weight gained earlier in life.
Exactly. Particularly weight gain during childhood and adolescence. That's a leading theory. There's a large 2019 study, over 85,000 women. It found those with a body mass index over 30 had nearly double the risk of developing early-onset colorectal cancer compared to women with a lower BMI.
Double the risk just from obesity.
And it seems to go deeper. Weight gain from age 18, obesity during adolescence, even maternal obesity during pregnancy are all being implicated. This suggests that exposures very early in life, maybe even before birth, could be playing a role.
So it's not just about your habits right now, but potentially this long-term developmental track, almost like a cumulative effect starting really young.
Precisely. It frames it as potentially a lifelong exposure issue. And beyond weight, there's the Western-style diet.
Which is generally characterized by?
Well, being more sedentary, less active, and high consumption of things like sugar-sweetened beverages. Think about the major shifts in how we eat and move compared to, say, 50 years ago.
Makes sense.
Another one is metabolic dysfunction-associated steatotic liver disease, or MASLD.
That used to be called non-alcoholic fatty liver disease, right?
That's the one. Basically, fat buildup in the liver not caused by alcohol. That condition itself is also rising globally, and it's proving to be a significant risk factor for colorectal cancer, even in people who aren't overweight.
So it points to broader metabolic health issues.
It does. It highlights this wider metabolic dysregulation that's becoming more common. And finally, alcohol use and smoking are both associated with increased risk too.
Standard culprits for many cancers.
They are, though the link for smoking, specifically with early-onset colorectal cancer, is maybe a bit less clearly established than it is for average-onset cases, where it's a very strong link. But taken together,
It paints a picture.
it really does. These modifiable factors suggest our modern lifestyles are creating this vulnerability. It seems these ways of living, which are so common now, aren't just leading to chronic diseases later in life anymore, but might actually be priming younger bodies for these early cancers. It's a stark reminder that choices, maybe even exposures starting very early, have these profound consequences that are now showing up much sooner.
That really connects the dots between these trends and broader societal changes. But what about genetics? Is this all down to lifestyle, or are these inherited cases? Is it just bad luck passed down in the family?
That's an excellent question, and it's a really important distinction to make. So germline pathogenic variants, those are the inherited genetic changes passed down through families. They are indeed more common in early-onset GI cancers than in later-onset cases.
Okay, so genetics does play a role.
It does. For example, they're found in maybe 10 to 25% of early-onset colorectal cancer cases. But here's the crucial part. The vast majority of these early-onset cases occur sporadically.
Meaning not inherited.
Exactly. Meaning they're not caused by an inherited genetic mutation we can identify right now. They likely arise from a combination of other factors, probably those environmental and lifestyle ones we just discussed, may be interacting with some common genetic variations that aren't disease-causing on their own.
I see.
Common inherited conditions linked to these cancers include things like Lynch syndrome and familial adenomatous polyposis, but again, they only account for a smaller fraction of this big overall increase we're seeing.
So while family history is definitely important for some individuals, the sheer scale of the rise points away from genetics being the primary driver for most people.
That's the current thinking, yes. The environmental and lifestyle shifts seem to be the bigger story explaining the population-level trend.
Which brings us to another critical and, honestly, quite heartbreaking aspect, the actual experience of the patients. It sounds like these younger patients often face significant delays in even getting diagnosed.
That's unfortunately true, and it's a major, major hurdle.
You can sort of imagine why, right? A healthy-looking 30-year-old dismisses symptoms. Maybe their doctor does too.
Exactly. The research really highlights this. Neither doctors nor the patients themselves typically suspect cancer in younger people. It's just not top of mind. And this lack of suspicion leads to significant delays in diagnosis.
And the consequence of that delay
Is that doctors are more likely to diagnose these patients at more advanced stages of the disease, stage 3, stage 4, and often the cancer itself seems to have a more aggressive biology.
meaning it grows faster or spreads more easily.
Potentially, yes. For instance, the tumors might be poorly differentiated, which suggests faster growth. And common symptoms, things like persistent rectal bleeding, unexplained abdominal pain, significant changes in bowel habits, these might get dismissed as something else, like hemorrhoids or irritable bowel syndrome, for far too long in a younger person.
So that delay is critical. It's a tragic pattern.
It really is. Increasing awareness, both among the public and physicians, is vital.
And then there's this treatment paradox you mentioned earlier. Despite not having clear evidence yet that it improves survival, younger patients often seem to get more aggressive treatment. Why is that?
It is a paradox, and it's something the medical community is actively debating. Official guidelines are often the same for early onset and average onset cancers, but in practice there is definitely a tendency for younger patients to receive more intensive chemotherapy regimens, maybe multiple drugs, and more extensive surgeries.
Why? Is the thinking just, they're young, they can tolerate it?
That might be part of it. Let's hit it as hard as we can because they have their whole lives ahead of them. But there's emerging data and ongoing trials actually suggesting that de-escalating therapy could be a better approach for some.
De-escalating, meaning less treatment.
In carefully selected cases, yes. For example, potentially omitting chemoradiotherapy before surgery, or even omitting surgery altogether in some cases of localized rectal cancer, where chemo and radiation have had a great response. The goal is to achieve the same cure rate, but crucially, preserve quality of life.
Which is so important for someone facing decades more life after treatment.
Absolutely. Living with the long-term side effects of aggressive treatment for 40 or 50 years is very different than for 10 or 15 years. We're also seeing some promising, though still early, data on using liver transplantation for colorectal cancer that spread only to the liver but can't be surgically removed otherwise. This could be particularly relevant for younger, generally healthier patients who might be good candidates for such an intensive option.
That makes sense. Beyond the purely medical side, though, this is where the human impact really hits home. What are the unique psychosocial and financial struggles these younger patients face? I imagine it's a whole different ballgame compared to someone diagnosed in their 60s or 70s.
Oh, absolutely. The burdens are immense and multifaceted, and they hit at such a vulnerable life stage. Financially, think about it, these patients are often in their peak earning years.
Just starting careers, maybe, buying homes.
Exactly. Maybe raising young children. A cancer diagnosis can throw a massive wrench into all of that, leading to much greater financial strain compared to older individuals who might have more savings, be closer to retirement, or have different insurance situations.
And the family impact must be huge.
Immense. Just the sheer difficulty of explaining a serious diagnosis like cancer to young children and then navigating huge decisions about potentially growing or starting their families.
Which brings up fertility, right? Treatments can often impact that.
Fertility is a critical and, sadly, often unmet need. Despite recommendations that oncologists should discuss treatment-related fertility risks, one recent study was quite shocking. It found over half of patients reported their doctors didn't talk to them about the impact on having children in the future.
Over half? That's terrible.
And over 75% did not undergo any fertility preservation procedures, like freezing eggs or sperm. Cost, unfortunately, is often a major barrier there.
So they might lose the chance to have biological children without even having the conversation or options presented properly.
It's a major gap in care. And then looking longer term at quality of life for survivors.
Right.
Early onset colorectal cancer survivors are more likely to report significant problems with anxiety, with body image issues, with sexual dysfunction compared to older survivors.
That makes sense given the life stage.
They also often report worse social functioning and overall physical quality of life. And interestingly, male patients with early onset colorectal cancers seem disproportionately affected by depression. It highlights the profound, long-lasting psychological toll.
That's such a sobering picture of all the ripple effects. Is there any specialized support emerging to address these very specific needs? Because it sounds like standard cancer support might not cut it.
Thankfully, yes. There's growing recognition of this need. Specialized centers are emerging, like the Young Onset Colorectal Cancer Center at the Dana-Farber Cancer Institute. They're specifically designed to address these unique challenges.
What do they focus on?
Things like dedicated patient navigation through the complex health system, connecting patients with peer support, others going through the same thing, providing tailored psychosocial care, and really streamlining the process for genetic testing and counseling. It's about providing holistic care tailored to this distinct population.
That sounds incredibly valuable. Okay, so given these rising rates in younger adults, it feels obvious that our traditional screening approaches need to change. How are these trends already impacting official recommendations, especially for colorectal cancer?
They absolutely are changing things. In 2021, the United States Preventive Services Task Force, that's a key independent panel, they officially lowered the recommended age to start colorectal cancer screening from 50 down to 45 for average risk individuals.
So age 45 is the new 50 for screening.
For average risk people, yes. This was a direct response to the data on increasing early onset cases. But there's a but.
Okay.
Adherence remains a huge challenge, especially in that new target group, the 45 to 49-year-olds. Many people who are now eligible just aren't getting screened. Maybe the message hasn't fully sunk in, or perhaps the idea of needing cancer screening at 45 still feels, well, premature to many.
Right, getting people to actually do it is key.
Exactly. And looking forward, while colonoscopy is still seen as the gold standard for detection, there's growing evidence that annual stool-based tests, like the fecal immunochemical test or FAT test, could be just as effective for detecting cancer, especially done consistently every year.
Those are the less invasive tests you can do at home.
That's right. They could significantly improve access and adherence, especially for populations that might face barriers to getting a colonoscopy. It offers another valuable option. But screening is only part of the picture.
We still need to understand the why better.
Absolutely. The need for continued, really focused research into the underlying causes and the unique biology of these early onset cancers is paramount. Sarah Char, the lead author of that BJS paper we mentioned, put it perfectly. She said, I'm quoting here, "Ongoing research efforts investigating the biology of early-onset gastrointestinal cancers are critical to developing more effective screening, prevention, and treatment strategies."
So we need to get under the hood and see what makes these early cancers tick, essentially. Is it different from later onset cancer?
That's the multi-million-dollar question.
Yeah.
We need what are called multi-omics approaches. Think of it like building a complete profile of the cancer and the person.
Multi-omics, what does that involve?
It means integrating different layers of biological information. Genomics, the person's underlying genetic code. Epigenomics, how those genes are switched on or off. Metabolomics, the chemical byproducts of the body's processes. And the gut microbiome, the trillions of bacteria living in our gut, which we know play a huge role in digestion and immunity.
So looking at everything from genes to diet to gut bugs.
Exactly. Combine all that data, diet, lifestyle, genes, gene activity, metabolism, microbiome, ideally from large groups of people, maybe through international tissue banking efforts. That gives us the best chance of finding the specific drivers and unique features of early onset cancers.
And what about treatment trials?
That's another gap. We currently lack solid data from randomized controlled trials to guide specific treatment decisions differently for younger versus older patients. We're often extrapolating. So it's really crucial that future clinical trials testing new therapies build in specific analyses for younger age groups. We need age-specific data.
That makes total sense. Which brings us, I think, to our final thought for you, the listener. As we reflect on all these alarming trends in early onset GI cancers, so strongly linked to modifiable lifestyle factors and exposures maybe happening decades earlier. What does this really tell us about the broader ripple effects of, well, modern living on our long-term health?
It's a profound question, isn't it?
How might understanding these early life exposures, diet, environment, metabolism, how might that be the absolute key to preventing these diseases for the generations coming up behind us?
I think that's exactly where we need to focus. Addressing this growing crisis won't be simple. It's going to require a really comprehensive, multidisciplinary approach involving doctors, researchers, public health experts, policymakers, and it needs to be equity-based, addressing those disparities we talked about.
Right.
We absolutely need to move beyond a one-size-fits-all model, both in clinical care and in our research, to truly understand and meet the unique needs and vulnerabilities of younger populations facing these cancers.
So maybe something for you to think about is what public health initiatives related to diet, exercise, metabolic health, and early disease detection are happening in your own community? Understanding these shifts, being aware, and perhaps advocating for change, that's really the first step toward a healthier future, not just for ourselves, but truly for the generations to come.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.